Hello and welcome to HND in Healthcare Practice. We are going to look at today Unit 22, Supporting Individuals Through Significant Life Events. So the learning outcomes for this module are to assess the impact of significant life events on individuals and social networks, review the role of external agencies that provide support for individuals and their social networks going through a significant life event, explain how organizational policies and procedures support individuals and their social networks affected by significant life events, and to reflect on how individuals who have experienced significant life events are supported in care service provision. So today we're going to talk about the topic of pregnancy, birth, fertility, and starting a family. And we're going to think of these as the significant life event. And it would be particularly relevant to start off with some definitions. So firstly, pregnancy. Having a child or an offspring developing in the body with a child or young as a woman or female mammal. Now that's a very generic description that's taken from the dictionary, but obviously we're thinking about that, having and carrying the baby, having and carrying a child. Fertility. So fertility is the ability to produce offspring, or the power of reproduction. So again, we're thinking about the journey to carrying that child, the ability to carry a child. And family, we're thinking about a social unit containing one or more adults together with the children they care for. And that social unit can consist of, single parent families. We're thinking perhaps about multi-generational families where we have grandparents, parents, and children within a household. And we're thinking about the wider extended network as well. And then finally, surrogacy. So surrogacy is the state of being a surrogate or a surrogate mother. And this is obviously something that is particularly relevant when we think about fertility. So we're talking about the connection between perhaps a female or a homosexual couple or a single male who are unable to produce a child themselves and engage the services of a female who can reproduce or can bear children to carry the child for them. So we're going to start off by watching a video that just sort of introduces the topic today.
It is risky to talk about pregnancy, so here's a trigger warning. Some of you want to be pregnant, and for whatever reason, are not. Sometimes people get pregnant when they don't want to. In fact, half of all pregnancies are unplanned. Sometimes pregnancy is the traumatic result of sexual assault. Other times, a pregnancy can be so medically complicated, it threatens the life of the person who carries it. Some pregnancies will come to a devastating end, stillbirth. And I am not talking about those pregnancies today. So if that was your pregnancy, you might be offended. But the truth is, those pregnancies need way more time than I'm given today. What I want to talk about are the uncomplicated pregnancies. Because when a pregnancy occurs, people are changed forever, no matter what the outcome. I'm a pregnancy expert. I've been a physician since 2008 and an obstetrician since 2014. I've also experienced 2 pregnancies of my own, so there's that too. Most people who become pregnant start out with one of 2 goals in mind. 1, they want to have sex. 2, they want to have a baby. Sometimes it is both. Most people who get pregnant don't actually want to be pregnant. Pregnancy is a means to an end. It is usually not the goal. Let's talk a bit about physiology. This is the study of how our bodies work. And there are dramatic differences in the physiology of a body when it is pregnant compared to when it is not. From the moment of conception, when sperm meets egg, the pregnant body begins to change. And it does this in order to provide a place for those few cells to grow into a whole new person. And those changes can be felt in a number of different ways. You may not be interested in learning about this at a scientific level, but you can probably relate to most of the symptoms. Think about a time when you had a stomach bug and it caused nausea and vomiting. You were probably pretty miserable for those few days. Morning sickness can be all-day sickness, and it can last through 9 months of pregnancy. Imagine if we advertised pregnancy the way certain drugs are advertised. Are you ready to become a parent? Wanting to add a branch to your family tree? Talk to your doctor about pregnancy. Pregnancy may have any of the following unwanted side effects: nausea and vomiting, heartburn, insomnia and snoring, frequent voiding both day and nighttime, shortness of breath, heat intolerance, sensitivity to smells, nosebleeds, sinus congestion, abdominal cramping, back pain, hip pain, leg cramps, varicose veins, constipation, hemorrhoids, skin rashes, stretch marks, itchy skin, acne, skin pigment changes. I bet you're having some doubts about this drug they call pregnancy. And yet, some people will talk to their doctor about pregnancy because the ends justify the means. And for some people, pregnancy is a really great experience with minor, short-lived discomforts. And there can be this amazing feeling of pride in the body that allows a place for this new person to grow. It can also be a time of great anxiety. Postpartum depression gets a fair amount of press, and rightly so. But mood disorders often start in the pregnancy, only getting worse with the hormonal changes that happen after birth. Anxiety during this time is no less significant or important. People who are about to become parents are under a great deal of pressure. Often this is pressure they put on themselves, but it can also come from family, friends, parenting groups, and social media. When we see a pregnant person, there's this need to comment, a need to acknowledge. Unfortunately, our comments are often peppered with advice and warnings that are largely based in myth, not fact. So how do we address this? During a routine prenatal visit, the patients have their agenda, and I have mine. I'm screening for symptoms of complications, measuring blood pressures, checking growth, and so on. The other half of the appointment is dedicated to answering questions and addressing concerns. And many of those concerns come up as a result of comments that have been made to the pregnant person. And these tend to increase anxiety. Some common myths regarding what is and is not safe in pregnancy revolve around food and drink. And coffee is often a target here. But this has been extensively studied. In part, I think, because we medical professionals seem to live off the stuff. So this was an important one for us to suss out. I've seen pregnant people being given decaf that they neither ordered nor paid for because of this assumption that caffeine is unsafe in pregnancy. There are lots of good studies that say regular coffee is okay to drink when you're pregnant. Deli meat, soft cheeses, sushi, and rare steak are things that you'll often see on lists of foods that should be avoided in pregnancy. But the issue here is not the food. It has everything to do with bacteria that can contaminate food, and maybe more often some of those listed. Listeria is an example. This can cause a serious infection, and if it happens to you when you're pregnant, it can cause harm to you and your fetus. But if you pay any attention to the news, you know that food recalls are fairly common, and listeria is frequently the culprit, even in salad. Nobody is telling pregnant people to stop eating salad. Proper food handling and preparation can decrease the risk of exposure. So a pregnant person who's eating a deli meat sandwich or their favorite sushi roll is not doomed to suffer an infection. Remember, it's not the pregnancy that makes them sick. So please resist the urge to offer dire warnings of harm to the baby if they are eating these foods, especially if you are about to eat the same foods. If you eat contaminated deli meat, your status as not pregnant will not protect you. Contaminated foods don't know if you're pregnant. Alcohol is a thing I get asked about. Total avoidance of alcohol is recommended in pregnancy. Oh, but everybody's got a story of Grandma so-and-so who sipped whiskey through her 16 pregnancies, and those kids all turned out okay. I've also heard that a small glass of wine every day is common in some countries or cultures. The problem is, we know alcohol consumption in pregnancy is associated with fetal alcohol spectrum disorder. What we don't exactly know is how much or when alcohol is a problem. A robust study that exposes a population of pregnant people and their fetuses to alcohol would have a hard time getting ethics approval. So the recommendation is total abstinence. Yes, even in France. Sex is another thing that people wonder about in pregnancy. Is it safe? Can we do it? Am I going to hurt the baby? Some people feel so terrible in pregnancy, they just don't want to have sex, and that is okay. Other people feel amazing and experience this increased sex drive, wanting to have sex more than they ever have before. That's okay too. The pregnancy is well protected inside the uterus. So if you're wondering if the fetus is being poked during sex, the answer is no. Not directly, anyway. Some complications of pregnancy do make sex unsafe. But when that's the case, the physician or midwife should be making that explicitly clear. Some people think that any level of exercise in pregnancy is unsafe. This can be taken way too far. Exercising when you're pregnant is very different. You're short of breath more easily, your center of gravity is off. But there are many studies that show physical activity is beneficial to the pregnant person's health and their pregnancy outcomes. It's probably not the time to take up a new extreme sport, but if a pregnant person was running marathons or working a physically demanding job before they got pregnant, they can probably continue doing so for most of the pregnancy. It is okay to be lifting things or standing for a good part of the day. Simply being pregnant is not a reason to stop running or lifting or cycling or climbing stairs. Most people who are pregnant will have a hard time sleeping at some point. They're waking up to pee. They get leg cramps and other body aches. And some people are told that certain positions are unsafe to sleep in when you're pregnant. They get told, don't sleep on your back. Don't sleep on your stomach. Don't sleep on your left side or your right side. Do you see why this is a problem? Some people have told me that they're setting alarms to wake themselves up and make sure they're not sleeping in an unsafe position. Here's the take-home message on sleep in pregnancy. If you are comfortable, you are safe. Stomach sleepers can absolutely remain stomach sleepers, at least for a while. When that belly is sticking out too far, it's just not happening. Left side, right side is a-okay. Back sleeping can be a problem. When the uterus is big and heavy, it can put enough weight to prevent blood flow coming back from the legs through the big vein and into the heart. But in a healthy individual, when this happens, the heart responds by beating faster. And this makes you breathe heavily, as though you're running. So if that happens when you're asleep, it has the effect of waking you up. You change positions and problem solved. No need to be setting any alarms. In the hospital, if a pregnant person is unconscious or immobilized, I place a wedge under the right hip, and that's enough to tilt the uterus off the big vessels and preserve blood flow. Pregnancies are self-sufficient. They're well-protected, well-designed systems that require very little day-to-day maintenance. I'm sad when I meet a pregnant person who in the first trimester has quit working to take care of the pregnancy. This usually is not necessary. Staying connected, getting out of the house, and being physically active are all going to benefit the pregnant person. And when miscarriages happen in 20 to 25% of pregnancies, it gives the wrong impression that activity is a cause. The bottom line on advice in pregnancy is it usually comes from a place of sincere concern and caring. But on the receiving end, it does little more than increase anxiety and pressure and guilt. One of my biggest pet peeves as a care provider for pregnant people is when someone comments on a pregnant person's size. That's body shaming, and it's never okay. Part of routine prenatal care includes measuring growth and investigating when there's a concern. We're all over this. I ask you all to think, have you ever commented on the size of a pregnant person's abdomen? Did you say someone looked huge? Ready to pop? Did you tell someone they looked small or barely looked pregnant? Have you ever told a pregnant person they looked just right? When we comment on the size of a person, it is almost universally negative. Big or small, they blame themselves for doing something wrong. And remember, this thing's gotta come out eventually. Anticipating labor and delivery is rarely without fear and dread. Let's agree, it hurts. Even when the outcome is highly anticipated, when a person can't wait to meet this new baby, they don't tend to be overly excited about the labor part, or the delivery part, or the recovery part. My training as an obstetrician prepared me well for the complications. But fortunately, most pregnancies and deliveries are uncomplicated and everybody comes through it okay. I feel that my most important role in the care of those pregnancies is a supporting role. And I've started teaching my patients to respond to unsolicited advice and comments like this. My doctor says I'm doing great. And I urge them to try and ignore comments as much as possible. But if something sticks, I want them to ask me about it. Then we can look at the evidence and make an objective assessment. The supporting role is one I take into the delivery room as well. Even in a normal labor and delivery, fear is still present. The experience is intense. Pushing to deliver a baby requires a person to go against a powerful instinct of self-preservation. We are all programmed to retreat from pain. But delivering a baby asks the pregnant person to push into the pain, to intensify it. And witnessing the strength it takes to do this is the greatest privilege of my job and my life. When all goes well, none of my high-risk skills are needed. But in that moment, when a person believes they can't do it, that is when what they really need is someone to say, "You've got this, and I've got you." And we can all do that. Offer compassion and understanding and support every day. So if you see a pregnant person and feel compelled to comment, why don't you give this a try? "You look great. How do you feel? Can I offer you a seat?" Thank you.
So that video sort of outlined the initial stage of thinking about pregnancy and about supporting women through pregnancy. So what we're going to do just now, we're going to start activity 1. So if you're following along online, we're going to pause the recording at this point and think about how do we provide initial care for a pregnant service user? What steps should we put in place once someone is pregnant? Who would we refer a newly pregnant mother to for continued care and support? And what support can we put in place for a staff member or co-worker who is pregnant? So if you're following online, just pause the recording here. Okay. So how do we provide initial care for a pregnant service user? Well, we start off by, confirming the pregnancy. We want to make sure that that pregnancy is in fact the correct diagnosis from a medical perspective, and making sure that, we have confirmed last date of period, confirmed potential conception dates. All of those things need to be factored in. Once we've confirmed that status, we're going to move forward and start to think about referrals for care. So we're going to start by referring to our community midwife team. So that will be done through the GP service. Ring up and speak to the receptionist at a GP surgery and book in to inform them so that your medical notes can be updated. If you've had a particularly high-risk pregnancy before, then obviously following that up to make sure that that is recorded that you have a previous pregnancy. And if you're a first-time mother, it's going through and booking which local hospital you would like to have your baby at. What support you perhaps feel you need at this time. So, like we've talked about before, point 3, who would we refer that newly pregnant mother to for continued care and support? So we have got our community midwives, who obviously will provide the initial care and support. If there are concerns within healthcare, we can refer someone into an early pregnancy unit for early reassurance scans. We can also think about referring for private healthcare and private sonography to confirm the pregnancy and confirm that there are no complications or issues. Point number 4, what support can we put in place for a staff member or co-worker who's pregnant? So within the initial confirmation of pregnancy, as soon as we've been notified as a manager or notified as a senior member of the team, we need to start off with a risk assessment, a pregnancy risk assessment. And this needs to come fairly soon, especially within the care sector, because we need to make sure that we're not giving unnecessary workloads to our staff and that we're factoring in allowances for morning sickness and for time for appointments. And this leads nicely into what we're going to start talking about next, what the law says about pregnancy. So people who are pregnant have 4 main legal rights. We have the right to paid time off for antenatal care, the right to maternity leave, the right to maternity pay or maternity allowance, and protection against unfair treatment, discrimination, or dismissal. And we're going to go through these in a little bit more detail. So, antenatal care and paid time off. This isn't just medical appointments. We're thinking about parenting classes. We're thinking about perhaps early reassurance scans, time to go to the early pregnancy unit. all of this is entitled as time off. Employers cannot change contract terms once a pregnancy has been raised with the management team. If they do that without agreement, then they are breaching a contract. So if we're providing care for somebody, perhaps we're part of the midwifery team, perhaps we are a manager within a service, we need to make sure that we are providing support in line with their original contract. Employers must give pregnant employees time off for antenatal care, and they have to be paid their normal rate for this time off. There is no variation at all. This time is paid at a normal rate. The partner or the father of the pregnant woman has the right to unpaid time off to go to 2 antenatal appointments. And the law is very clear around this. Anything beyond that is at the discretion of an employer. If we think about pregnancy-related illnesses, so maternity leave and statutory maternity pay will automatically start if an employee is off work for a pregnancy-related illness in the previous 4 weeks before the baby is due. And it doesn't matter what has previously been agreed. This comes directly from pregnancy law. If we think about maternity leave, so if an employee is not taking statutory maternity leave, they must take 2 weeks off after the baby is born, or 4 weeks if they work in a factory. And that also applies to those working within the care sector as well. So we need to think about the support and care that may be needed for individuals who are perhaps moving and handling or undertaking higher risk jobs within the care sector. Thinking about telling the employer. So an employee must tell their employer at least 15 weeks before the beginning of the week the baby is due. And if this is not possible, for example, if they don't know they're pregnant, or perhaps they have only found out relatively later on, the employer must be told as soon as possible. Employees must also tell the employer when they want to start their statutory maternity leave and their statutory maternity pay. And they cannot take time off for antenatal appointments until they have told the employer about the pregnancy. Once an employee has told their employer they're pregnant, we need to think about risk assessments to the employee and the baby. And this is what we touched on a little bit earlier. So we're thinking about the risks caused by heavy lifting or carrying, the risks caused by standing for long periods of time or sitting for long periods of time without an adequate break. We're thinking about exposure to toxic substances, and we're thinking about long working hours. At this point, there are other risks that we can think about, but what we need to think about is where there are risks, the employer should take reasonable steps to remove them. So for example, changing the workload, changing the working hours that we set out for our employee. Perhaps we're thinking about, removing the heavy lifting from a workload. And if an employer cannot remove those risks, they have to suspend the employee on full pay. Okay, so that is enshrined in law. If we cannot mitigate the risks to a pregnant person and their baby, we must suspend them on full pay. Pregnant employees who think they're at risk, but their manager or employer disagrees, should talk to their health and safety officers, their trade union representatives, and if they still refuse to do anything, we can escalate this to our doctors, or we can contact the health and safety executive, who are a branch of the government. So we're going to talk now a little bit about the Equality Act. So one of the protected characteristics from the Equality Act is that anyone who is pregnant cannot be discriminated against. And we're thinking about either direct or indirect discrimination, harassment, or victimization. So regardless of that pregnancy, people should receive the same treatment as other individuals. So now we're going to touch a little bit on pregnancy and emotional well-being, because obviously we recognize that as much as pregnancy has its physical symptoms, it can also have quite a profound effect emotionally on someone. So we're going to watch a video just now that explores the topic of pregnancy and emotional well-being.
When I ask, "How are you?" you may even answer, "I don't know." My name is Greta Gill. I'm a certified nurse midwife. You probably have some pregnancy discomforts come to mind right away. Oh, I'm tired, I'm uncomfortable, I'm swollen, my back hurts, my bladder feels too small. But what I'm really asking is, how are you? Pregnancy emotions are powerful and ever-changing, and sometimes you can feel like your moods are in control rather than the other way around. And so I want to bring light to how common and normal the experience of going through all kinds of emotions is during pregnancy. But I also want to give you information on what's not normal and when you may need to seek help. So getting back to the question, how are you? You may answer, I'm so excited. I'm full of joy. I can't wait to meet my baby. This is the most invigorating time I've ever experienced in my life. And if that is you, then I say celebrate and be ecstatic and enjoy it. You may say, I'm nervous, I'm scared, I'm unsure, I'm worried. And I also want to say that is normal. That's part of the work of pregnancy, because all of these things are happening. The magical formation of a new baby, your body is growing the baby, your body knows how to birth the baby, and your body knows how to nourish the baby. And all of that is happening without you having to think about it. It's not in conscious control. Of course, you are in control of what you eat, and you do choose to get prenatal care, and you can choose to exercise, and you can choose to take a prenatal vitamin or not to smoke. But a lot of what pregnancy is surrendering to what your body knows how to do, and to have trust and faith in that process. When I ask, how are you? You may even answer, I don't know. I feel ambivalent. And I want to say that that's also really common. Makes sense that it is, because 50% of pregnancies are not planned. And so many women find themselves in a state of not feeling sure, of having to grapple with conflicting emotions, or changing plans or changing relationships. And I often say to my patients that, though pregnancy lasting 40 weeks can feel like a really long time and a huge test of your patience, it's probably also a blessing, because that 40 weeks gives you time to transition. It gives you time to work in relationships, to change where you're living, to adjust in your job, to do all the things that you need to do to prepare for this newest member of your family.
So, thinking about that emotional roller coaster that pregnancy can be, it can be stressful and exciting, and so many emotions can be expressed. But I just want us now to, if you want to, pause the recording and think about, how do we emotionally support a pregnant person? So what can we do to make sure that when someone tells us that they are pregnant, that we're there for their emotional needs? So we're just going to pause the recording now. Okay, so emotionally supporting a pregnant person. The emotional support that we actually need to think about is just being available, being there so that when someone has a question, especially as a practitioner, being there to listen to concerns, being there to, ask the question, how are you feeling? What can I do to support you? Being available and making sure that we have built time into our schedules to allow for those questions to be asked, allow for questions from, not just the person who's pregnant, but their support network as well. So when we think about, providing care and support, we need to build that into, our appointment times. If we're working with the midwifery team or with the GP, perhaps we need to build that into our service plan of, giving someone that extra bit of time just so that they can communicate. So if you're following online, this would be a really good point to take a break. So if you want to take a 15-minute break just to refresh yourself, and we'll come back in 15 minutes. Okay, welcome back. So now we're going to move on to the topic of birth. And we're going to look at a few different types of birth and explore birth as a concept and as a significant life event.
How long will your anaesthetist be? I don't know, because the lady's just going down now, so... I don't know. It's entirely your choice, whatever you... What do you think?
Does he have a rough idea of how long it'd be?
I mean, I'd probably
hour?
say a good hour.
Yeah, I'll have the mouthing then.
Okay. We'll have to get you out of here and
It's up to you.
It's fine.
get you back down to the room.
I don't want to stay here. I want to lay down.
Yeah.
You want to get out?
Yeah.
Okay.
Well done.
That's it. It's okay.
Brilliant.
It's good, Leah.
Just give it all you've got. Give it all you've got. You've just got to give into it. I know it's a really horrible feeling, but you've just got to go with it. Nice and steady, steady, steady. A little bit more. Steady now. Beautiful. Right, that's it. Just blow your baby out, Leah, blow your baby out, blow your baby out, blow him out, blow him out, blow him out, beautiful. Brilliant. He's coming.
It's alright, Leah.
He's here. Sweetheart, Leah, touch his head.
You're alright, Leah. You're alright.
It's alright. Okay. It's okay. Nice big deep breath. That's it. Perfect. Well done. Okay, it's nearly
It's out now.
Okay.
It's almost out anyway.
Just another little push for his chin, my darling. That's it. Oh. Hello, baby. He's got a bit of hair. It's quite fair. Don't force it, darling. Just when there's a contraction. Okay. You have to have the power of the contraction behind it. Have you got
contraction there. Go on. Big push. And go on, right down into your bottom. Well done.
Is that now?
Oh, that feels so weird.
Bungee jumping.
Is that out now?
Oh, yeah.
Is that out?
You did it. Well done.
I did it.
Leah, did you want that injection for your
Yeah.
side? Is that okay if I give that to you?
Oh, he's my baby.
He is your baby. Happy's fine. He's just a bit
Like fair.
That's all. I just get into him.
Oh, he's beautiful.
And I just ask you to roll back just a little bit, darling, because he's just a bit stunned, as are you, I'm sure.
Oh, he's gorgeous.
So that's it's quite a graphic video in terms of showing a delivery of a baby. But for a natural birth, that is just one perspective of hundreds of women who go through natural birth. And, you know, each experience of this will be different. But what we're going to do just now is going to pause the recording to talk about the impact of having a natural birth, talk about how you would support the emotional needs of a woman who may be anxious about delivering her baby. And then we're going to discuss how can birthing plans impact on the wider family network. So we'll pause the recording just now. And when we come back, we'll talk about this. Okay, so the impact of having a natural birth. Natural birth, we're thinking about, you know, using as little intervention as possible. So we're not using the equipment to deliver the baby. We're thinking about a woman going through and pushing out a baby. Now that's quite a scary process for someone, especially for a first-time mother. You know, that there's a lack of awareness of really what to expect. So if we're supporting that person, if we're thinking about that, you know, that's quite an exhausting time for someone. So we need to make sure that we're building in that extra time for care and support. We're building in that extra time to make sure that we're checking in and checking up on mum and keeping tabs on how the labour is progressing and post-birth, making sure that she is fully supported and has her needs being met. We're thinking about emotional support. So pregnancy is a time when there are a range of hormones pummeling their way through all of the systems of the body. So every aspect of a woman is feeling completely overwhelmed. And that can often result in quite an emotional response. So making sure that we have that time for someone to talk about how they feel about delivering their baby. Is there anything that we can do to support that delivery process? Perhaps we're thinking about calming music. Perhaps we're thinking about a birthing pool or a birthing ball, or exploring other sorts of things like what pain relief they would like during that process and what interventions they might perhaps want. If we're thinking about the birthing plan impact on the wider family network, we obviously have to look at who is going to be there to support mum. With the current pandemic, birthing partners have been restricted to one key person. So often enough, in particular social circles, that might be a woman who chooses her mother or her sister. In other groups and in other population groups, that might be a woman choosing her husband or her partner. But factoring in a normal perspective, the birthing plan usually includes one or two people. We also need to think about how that can impact on other family members. So perhaps if we've got a mum who has children before, we need to start thinking about ensuring that there is support there for her children who have already been born. Perhaps we're thinking about support for relatives who may want to visit or may want to see the baby after they're born. And it's all about that introduction and that integration of making sure that we don't just look at our pregnant mother, but we look at the support network as well and making sure that questions can be answered for everyone. So what we're going to do just now is look at another type of birth that we would typically see.
Has she got any allergies?
No.
Good.
They may decide, right, we need to do a category 1 caesarean section, which means the aim is to have the baby delivered within 15 minutes of the decision.
Right, Dad, I'll come and fetch you in a moment or two.
Does she need mittens?
No, mittens are fine. Thank you.
She doesn't need hats yet. No.
She's going to have lots of hair.
No, she
She
won't. Look at the
is.
father.
She'll soon be here. Don't worry, Joy.
Oh, I'm frightened. I'm scared.
I'm looking forward to the moment when they pass the baby to me and I can hold her in my arms. It's the sort of image I had in my mind really since the day we started talking about having a baby 5 years ago.
We're ready for you.
Excellent.
Come on.
This one? Right. Thank
There will be
you.
a screen up here, you won't be able to see the operation.
Right.
Please have a seat.
You all right? Sleepy.
What's the name of the baby? Elvis. Ellie.
So you might feel a bit more tugging on your tummy just for a second, coming out.
Pulling out. Hey, come on, Ellie. Come on, Ellie. Come on here. Right, come on, Ellie. I'll meet your mum. Hello, mum.
So, having thought about C-sections and particularly having seen an emergency C-section just there, we're going to pause the recording and just have a think about what emotional support do you think a mother would need? How do you think a family network would react to an emergency C-section? And what impact you think there would be for an individual and their family following a C-section? So just take 5 minutes, pause the recording, and have a little think about this. And when we come back, we'll discuss it. Okay. So, what emotional support do you think a mother would need? So one of the things that, particularly if you look at that scenario and that case, there's a lot of reassurance needed, you know, a lot of discussion around perhaps what's going to happen. How is this going to impact on their life? What effect will this have on the baby? Is it going to change what happens once the baby has been born? And all of this can be quite an emotional roller coaster for someone who is perhaps thinking that their pregnancy was going to be straightforward. Perhaps they were expecting a natural delivery. And to have this change can be quite unsettling. So we need to make sure, again, that we're building in that time for discussion. We're building in that time to answer any questions that may be asked, and making sure that we do regularly touch base prior to that emergency section to reassure the mum that, you know, this is a completely safe procedure. It has been undertaken, you know, thousands of times before, and that once baby comes out, that baby will be given the appropriate support if needed. So thinking then about how we support a family network and what their reaction would be. So obviously we could expect to see a bit of shock, especially if a pregnancy has been expected to be straightforward. We could see perhaps some worry in that perhaps there is concern about how mum will react to having a procedure, how that would have a serious impact on their family life. And we could certainly expect to see, you know, some concerns about perhaps, you know, what is going to happen? What is the process? Will they be allowed to see mum after the baby has been delivered? So it can be quite an emotional roller coaster as well for the family. But when we move on to the final point, the impact for an individual and their family after that C-section. So we know that the standard recovery time for any operation is 6 to 8 weeks. So we know now that a mum who has delivered her baby via C-section is going to have 6 to 8 weeks of needing to take it easier, needing to rest and recuperate, not to be doing any heavy lifting. If we're thinking about perhaps somebody who has expressed that they wanted to return to work, you know, in that 2-week or 4-week period after the delivery of their birth, we then need to, you know, make sure that we remind them that there will need to be consideration for their surgical care. So they will need to have a little bit extra time off to ensure that their wounds heal properly. We also then need to factor in that they will need follow-up care through the community nursing team and through community midwives to ensure that there are no infections in their wound, to ensure that the healing process has taken place in an appropriate manner, and making sure, again, that's followed up. We also think about the child, you know, following the birth. If the child has progressed nicely, we need to make sure that the care of the child can be supported. For a mum who has had a C-section, she's going to be particularly weaker. She might not necessarily be able to carry her child as much as she would want. So we need to make sure, again, that there's a support mechanism in place to support that mum. So we're going to watch another video just now, and let's watch this and then follow this up again with another activity.
So you have to remain calm, because otherwise you just wouldn't get through it if you didn't think about it methodically.
Everyone always thinks that it's not going to happen to them, and then all of a sudden you open these doors and it's a whole nother world behind the doors. When people get pregnant, you go into hospital or you have your baby at home, and then you go home afterwards and you have your normal, your well baby. That's what everyone ought to have, but you know, it's not always the way it works out. These babies do go downhill as well as uphill, and the parents kind of rung us up at 7 o'clock in the morning when they first wake up, and you know, they've been reassured by the night staff, oh yeah, I had a really stable night, nothing untoward's happened, everything's hunky-dory, and then they come in at 10 o'clock and face something completely different. A lot of babies are with us for the long haul. They're there for weeks and weeks. And that's very hard to see when you're at the beginning, when this mum has just delivered and she can't see that this baby's not going to be out for 8 weeks or 10 weeks. And that's very hard to see how that time is going to pan out. Parents get very excited about certain occasions, like when a baby first opens its eyes, and when a baby has its first poo, and everyone gets very excited about this poo that's come out. Whereas to a term baby, that would just be a normal process. But, you know, on the neonatal unit, when you're watching for every event, something like that is monumental, really.
You think birth is going to be lovely and normal and everything's going to be fine, you're going to have a lovely, healthy term baby, and they can't believe it. It's just unbelievable to them that their baby could be born prematurely. None of them expect to turn up at our doors.
Hello, Neonatal Unit room 3.
Some of the babies that we have are pretty close to the edge sometimes. You know, not all babies make it out of there. But more than the sad stories, you get the good stories, and a lot of people look back on their time with us really fondly, I hope. Yeah, we have a lot of happy endings.
Okay, so the neonatal unit is obviously quite an experience for parents who perhaps weren't expecting to have their child on the unit. And speaking from my own experience, walking into a neonatal unit as a member of staff, it's a very different environment to a typical hospital ward. You have machines beeping consistently, you have alarms going off, you have, you know, a high volume of staff present at all points. And it is a very unusual environment from a regular child's ward. So thinking about that, we're going to start and look at how would a parent feel if their baby was admitted to neonatal care? What impact does an admission have on their family and the family network? And how could we provide support to a parent whose child is in neonatal care? So pause the recording just now. Have a think about these questions, and when we come back, we'll talk through them. Okay. So how might a parent feel if their baby's admitted to a neonatal care unit? Well, as the video touched on, parents are often surprised and they don't expect the process. They are taken aback, and often there's quite a lot of emotion expressed from parents who believed they would be taking their baby home and that their baby would be healthy and happy. So we need to make sure that we can think about these things when we're providing care and support. If you were perhaps providing care and support on a maternity unit, it's about making sure the parents feel that they are engaged with the process, that they are involved at every stage and every step, and that all the information that can possibly be given to them is given to them. If we're thinking about our experience, perhaps from a community team, perhaps as a community-based service, we then need to make sure that, we're following up with the family, touching base to make sure that their emotional needs are being met as well. Which obviously this ties in again with the second question. So what impact does an omission have on a family? So we know that, for particular cases, parents will not be able to stay consistently next to their child. There may be limited availability for parents to reside with the child, and it can't, like the neonatal nurse expressed, things can change very quickly. So families can have a lot of tension and a lot of strain put on the relationships, and especially for some mums, the feeling can be that they're observing friends and observing people that they were on delivery suite with, who have got to take their baby home, and there can be feelings of envy, feelings of, feeling upset because their baby, they haven't been able to have that relationship with in the way that they expected or wanted. Providing that care and support. So if we're thinking about providing care and support, we need to acknowledge that, perhaps there needs to be that built-in point of checking in a little bit more, making sure that both parents feel supported, that their journey is, we document and make sure that the notes that we're regularly checking in with the family. Perhaps we need to be thinking about ensuring that further psychological help is offered through counselling services or perhaps through the GP. But it's about building that support plan around what the parents express they need. So we're going to just move on to the next activity, and we're going to think about the need for specialist care. So what I want you to do is pause the recording and think, why do we need specialist care in pregnancy and birth? Then, how, as a manager, could you provide training to staff about maternity care for service users? And number 3, what changes could you implement in your own practice to be more inclusive of maternity care? So just pause the recording here and have a think about these questions. Okay, so the need for specialist care in pregnancy and birth. Well, pregnancy and birth are a normal phenomenon, so we need to make sure that the care that's provided has detailed to the various things that can happen within a pregnancy and within a birth. Having midwives and obstetricians who are specifically trained to recognize the various complications that may arise, and also to support those who go through a normal pregnancy. It is a specialist level of care, and we would expect to see that care delivered by specialists who have trained for some time around the care and needs that would be given. If we're thinking about us as managers, how could we provide training to staff about maternity care? Well, perhaps it's about thinking about what our service users express they need. Perhaps that's maybe needing a bit more emotional support. Perhaps we need, if we are working in a service like a GP surgery, we need to think about how we would, ensure that all of our staff have an awareness of what pregnancy is and what a pregnant person may need throughout their care plan, and developing and recognizing the need to refer on to others who have specialist knowledge. The changes that we can implement in our own practice to be more inclusive is thinking about having that emotional availability for our service users, having that wider knowledge, knowing what pregnancy is and you know, taking that time that if we have a service user who comes forward who is pregnant, making sure that we have done our reading around that we have educated ourselves on what they may need, what support we can give, and how we can further develop their care plan to be responsive to that need. So is it that we perhaps need to make sure that they have, if it's a service user who's in a wheelchair, perhaps it's needing to make sure that we make sure they have regular turns, make sure that they aren't stationary for long periods of time, engaging with physiotherapy to reduce the risk of blood clots, all sorts of different measures that we might need to put in place. So the final part of this section, we're going to look at fertility and fertility treatments. So we've talked about the pregnancy journey and we've talked about the birth journey, but often enough, there can be issues around getting pregnant or maintaining a pregnancy. So we're going to watch a video just now about one woman's experience of fertility.
They say it takes a village to raise a child, but no one told me it would take a village of family, friends, and even doctors just for me to have one. I imagined it being like the nursery rhyme I sang in kindergarten. First comes love, then comes marriage, and then comes a baby in a baby carriage. I even imagined what my future child would look like. My reality, though, first came love, check. Then came marriage, check. And then I didn't know what my future held. I didn't know if I would ever have a baby in a baby carriage because I struggled with infertility for 8 years. 1 in 8 couples struggle with infertility. And infertility is defined as trying to conceive for 6 months to a year, depending on age, with no success. But what infertility really is scheduling an appointment to have sex with your spouse at the right time of the month. Infertility is having sex at the right time of the month, but still getting a negative pregnancy test. Infertility is having sex at the right time of the month, month after month after month, but still getting negative after negative after negative until you lose hope that you'll ever become a parent. Infertility is finally going to the doctor to see what the issue is because infertility can affect either the male or the female. Infertility is medications, appointments, and going to the doctor, sometimes going to Dr. Google to try everything and still getting nothing. Infertility is sometimes emptying out your bank account because after all those appointments, all those medications, all those procedures, they cost money. Infertility is expensive. And then, if everything you try up to this point doesn't work, you can graduate to in vitro fertilization or IVF for the very, very low cost of about $15,000 per cycle. And IVF is when the doctor takes the male sperm and the female egg and joins them together and implants them into the uterus with no guarantee that you'll get pregnant or walk away with a baby. So you see, infertility is not just struggling to conceive. It's struggling to keep it together. When you feel inadequate because your body is unable to do something that it was designed to do. When you get on social media and you see yet another pregnancy announcement and you're wondering, when is it going to be my turn? When you watch everyone have the very thing that you want and you can't control whether or not it happens for you. When you're happy for everybody else and yet sad for yourself. Infertility is an emotional roller coaster. And that's why it is so important to have a village. My village was great. My village consisted of family and friends and even strangers that I met online on support groups. They consoled me. They prayed with me. They talked to me. They supported me financially. They hung out with me when I needed to get out of the house. They left me alone when I needed space. And even though my village was great, my village wasn't perfect. I remember in 2017, year 7 of my journey, we had gotten pregnant again after having several disappointments, and this time was different because we went to the first ultrasound and everything was developing on track. And we went to the second ultrasound and we heard the most beautiful sound, our little baby's heartbeat. And then we went to the third ultrasound and we were ecstatic because we saw a perfectly formed baby with a head, with arms, with legs, with fingers, with toes. And in fact, in that ultrasound, our little baby was holding up 2 fingers as if to say, "Mom, don't worry, I'm all right." So my husband and I looked at each other and we said, we're finally going to have a baby. And so we allowed ourselves to get our hopes up. And then shortly after, our dreams were shattered because we lost the baby in the so-called safe zone in the second trimester when the chances of miscarriage decrease. And I felt like somebody had ripped my heart from my chest. And I couldn't take it, and I even went to see a professional counselor because I couldn't rationalize how I could do everything so-called right and still not get the result that I was expecting. And I reflected back to that ultrasound picture, and I realized what my little baby was really trying to say is, "Peace. Mom, I can't do this anymore." And I was so crushed because at that moment, I felt like, but I can't do this anymore. And one of the wonderful people in my village said, "Why are you taking yourself through all this just to have a child? Why not just adopt?" And I know they meant well. And I'm not against adoption because I'm adopted myself. But what they didn't understand is I had already decided that I was going to do everything within my power to try to carry a child for myself before I moved on to other options. And besides, I had already consulted with another professional. The professional? My 80-year-old self, of course. I looked at myself and I said, "Shara, if you make it to 80 and you didn't give everything that you had to try to carry the child for yourself, would you regret it?" And my answer was yes. So I decided to give it one more shot, and I'm so glad that I did because after 4 IVF transfers, after an ectopic pregnancy, after laparoscopic surgery, after over 700 needles, after spending over $55,000 just to try to conceive, on September 26th, on September 26, 2018, I delivered my son. And my 80-year-old self said, "Shara, this is wonderful. But this is not enough." And I remembered that I always wanted to write a book, but I never knew what I was going to write about. And after going through this experience, I said, this is it. So in 2018, while I was pregnant with my son, I wrote and published my very first book titled "I Still Want to Be a Mom," written to women struggling with infertility to help them plan for, prepare for, and pursue motherhood despite their obstacles. And I looked at my 80-year-old self for approval, and she said, "Shara, that is still not enough. What about the village? What about the fact that all these employers don't cover fertility treatments? What type of role are you going to play in that village?" And so earlier this year, I decided to start a foundation called the I Still Want to Be a Mom Foundation, founded to help women struggling with infertility, to help them spiritually, emotionally, and financially, to give them support throughout this journey. Because this affects so many people. If I were to stand up every 8th person in this room, That would represent the number of couples struggling with infertility. If I were then to turn around and stand up every fourth person, that would represent the number of pregnancies that end in loss. So that's 25% of this room is struggling with this. The other 75% represent the village. But what should the village know? Be considerate when asking someone when they're going to have a child. Maybe they've been trying and they don't want to tell you. Maybe they just had a pregnancy loss. And if they just had a loss, don't say, well, at least it happened now. There is never a good time to lose a baby. Instead, say, I am praying for you, and I can't imagine what that feels like. Instead of saying, if you just want to have children, you can take mine. Consider the fact that all they want is to have a child of their own, and you have yours. Instead, say, I know that you'll make a great parent someday. Instead of giving unsolicited advice, like if you just relax, it will happen, consider the fact that maybe they need medical intervention to get pregnant and it won't. Instead of assuming that your friend, your family, your coworker, the person around you is waiting too long to have children, consider the fact that maybe they are struggling with infertility or loss. There are so many people suffering in silence, silently waiting and wishing for someone, anyone, to support them throughout this journey. It takes a village to support those struggling with infertility and loss, and you are that village. Thank you.
Okay, so we're just going to go straight into the activity. On your own, take 5 minutes and think about how a couple may be emotionally affected by fertility issues. What impact can fertility issues have on the family network? Who can we refer a service user to for fertility diagnostics and treatment? And in respect to equality and diversity, how would you support a single person or an LGBT couple looking at fertility treatments? So just take 5 minutes to think about that, and then we'll come back in and discuss it. Okay. So, why might a couple be emotionally affected by fertility issues? Well, it can put quite a strain on a relationship. It can be quite upsetting for a couple, especially if they've gone through the process like the lady in that video, and they've tried and they have done everything that they possibly can, and it still hasn't worked. And it can take its toll emotionally and physically on a couple. She obviously mentioned that in that video about having to, undergo various different treatments, the cost that was implicated for those treatments. And unfortunately, when we think about fertility care within the United Kingdom, again, we think about a postcode lottery, and it can be very different depending on what area of the country you're living in. But equally, there are places that will not provide NHS-funded fertility treatments, and there are places that you will have to pay first before you can receive any NHS-funded care. So again, that can put quite a strain on a relationship. We're thinking about couples who are perhaps having to remortgage their house, perhaps couples who are having to take out a loan in order to afford this treatment. And, this again can have quite a lasting impact on a family. If we're thinking about the wider family network, we're thinking about perhaps jealousy from siblings, you know, perhaps a couple who are feeling jealous of, you know, a sibling who has perhaps been able to have a child quite easily with no complications. Perhaps we're thinking about families who don't believe in utilizing fertility treatments and believe that, you know, alternatives should be looked at. And again, we can see that fractured relationship happening between an individual, a couple, and their family and their friends and their wider network. So we need to make sure that we're, you know, if we're thinking about supporting an individual through fertility care, that we're aware of the tensions that can come across the family. If we're thinking about referring someone for fertility diagnostics, the first port of call is obviously the GP. Now, your GP can start routine tests, checking for hormone levels in women, checking sperm samples in men, perhaps taking a history, recording, you know, fertility windows. All of those different things can be done through your local GP. If we've referred to the GP or if we are perhaps working within the GP service, we would think about once we've completed that stage of referring on to specialist care. Now, there are various facilities across the country that will deal with fertility options. And these services provide a range from, you know, medication-supported fertility treatments to non-medicated treatments, thinking about intrauterine insemination versus intravitreal insemination. And we're looking at a range of different options, but we have to, you know, we would have to factor in what services are out there as well. Thinking about equality and diversity, we obviously, you know, within our practice, we don't discriminate. We don't, you know, everybody should have the same access to care and support offered to them. So perhaps if we're thinking about a single female, we're thinking about, you know, utilizing services like sperm banks in order for her to get a sperm sample. And of course, that process will still happen through intrauterine insemination or IVF. If we're thinking about an LGBT plus couple, then we could be thinking about perhaps a homosexual couple who will need surrogacy, or perhaps a lesbian couple who, again, one of them may need a sperm donor. And we can think about the variety of different methods to consider when we think about fertility treatments and the LGBT community. Particularly now, we can look at support for perhaps a trans man who has a desire to be a parent and will carry his child himself, but, you know, perhaps needs support from a sperm donor. And we have to think about gender dysphoria symptoms as well within that range of fertility treatments. But these are the sorts of things that when we have service users that come through and whom, you know, are from these particular diverse community groups, we need to make sure that we thoroughly read and research around the care and support that we should be providing. Okay, so what we're going to do just now, take 15 minutes, have a break, and after that 15-minute break, you can unpause the recording and we'll come back and talk a little bit about adoption. Okay, so adoption. So the story that we're about to look at is a story of a lady who I have been in communication with and has shared that she is quite happy to share her story with you. So we're going to talk about Moira's story, and Moira has an adoption story that has quite a few different factors that we as a healthcare professional or a social care professional need to consider. So Moira starts off by talking about her reasons for adopting. We've experienced 10 miscarriages over a 12-year period. Our experiences have been horrendous, but we kept trying because the desire to be parents was so strong. However, following the last miscarriage in 2012, we decided to draw a line under our attempts to conceive and look into adoption. We contacted our local authority in Scotland to ask for information and then asked for an initial meeting to discuss how to proceed. Following this first meeting, we were sent a letter outlining the reasons why they did not want to proceed with assessing us as adopters. These reasons included that we'd both been married before, suggesting that we were unable to resolve relationship issues, that I was unwilling to lose weight, despite receiving a letter from my diabetes specialist saying that to do so would destabilize my glucose control, that we had a dangerous dog breed in the home. Kira was a 9-year-old rescued bull mastiff who had cancer and no teeth and who died before we even received their letter. We almost gave up on our adoption dreams until we heard from an acquaintance that a local authority in England was looking for adopters outside of their geographical area for the safety of their looked after children. This agency met with us, assessed us, and provided training within the space of 1 year. When we attended the panel to approve us as adopters, we had barely been told of the panel's positive decision before we were being shown the profile of 2 little girls who they had matched to us. 3 months later, we brought our daughters home. Our family and close friends knew what we were doing by going through the adoption process and mostly supported us. Some were vocal about their opinions on this is nature's way to say that you shouldn't be parents and how adopting was an unnatural process, but we mostly ignored that. It still hurts though that some family members no longer speak to us. Our close family and friends treat the girls no differently to other family members, and we have had lots of support from my parents in particular. I think that going forward, if our attempts to conceive via a surrogate were successful, then I will limit who receives this knowledge. So, activity 8. Take 5 minutes to pause the recording and think about how might adoption and the adoption process impact on an individual's life. What might we do to support someone who is engaging in the adoption process? Thinking about the wider family network. What should we do to support the adoption process for someone? How do we support a colleague or employee who is trying to adopt? So just take 5 minutes to review these questions and think about them. And when we come back, we'll talk about the answers. Okay, so how might adoption and the adoption process impact on an individual's life? Well, perhaps we're thinking about, again, strained relationships, a process that is very invasive and questions every aspect of someone's life. And that can put a huge strain on a relationship. It can also be quite an isolating experience. Some people find that perhaps adoption, has established them differently from their friends, from their social network. and that can make them feel quite isolated and lonely. So we need to make sure that we're thinking about how we can support someone, how we can provide that continued care and support. And again, some of this is around just having that listening ear, being there and giving extra time to provide support, making sure that someone feels listened to. Perhaps if we were working as part of the social work department, we might make extra appointments to go through and talk about what to expect. Perhaps, like with Moira's story, we want to look at perhaps the support sessions and the training sessions that are offered, and maybe building extra time into that to allow communication, to allow questions, to allow the process to be explored on a deeper and more emotional level. If we were thinking about the wider family network, perhaps that's about having an event where family can gather to discuss their concerns, or providing pamphlets or leaflets that explore how to talk to family members about the adoption process. But again, it's about focusing on what that individual expresses is their need. So how do they feel, and what do they feel would be the support that they need when engaging with their family? If we're thinking about colleagues or employees, again, there are rights enshrined within law about employees for adoption. And there is obviously adoptive leave and parental leave that can be granted. And again, as a member of staff, we need to make sure that we have thoroughly researched this as a manager or as a team member, and ensure that we are following to the law what support we should be offering. So we're going to look just now at the second part of Moira's story. So this part of the story specifically deals with support from professionals. For the first few weeks and months of the placement, we had weekly visits from the girls' social worker, which went very well. We also had monthly reviews to include the girls' social worker, our caseworker, the nursery manager for educational input, and the local authority. And they were all invited to attend out of courtesy. The local social worker tried to dominate the meetings, but was talked down by the responsible agency. It got very confrontational at times. We had a lot of support in the early stages by the English local authority staff, but the local social workers from Scotland were, and still are, difficult. Following the formal adoption being finalised in September 2014, responsibility for support passed to our local authority. We've had nothing but interference and accusations from them since. In the first week following our girls coming home, we had a first visit from a health visitor, as was required by their social worker. However, the woman's demeanour was off from the very beginning, and I had a bad feeling about her. I was proven correct when she reported us for neglect after that one visit. The English local authority dealt with the situation as they were responsible at the time, and knew that the girls were well looked after and had only been with us for a few days at that point. Despite being given information about their background and the youngest's special needs, the health visitor had seen fit to report us instead of offering support. In those early days, we felt very targeted, and still do over 6 years later. The initial thrill and excitement of finally having children in our lives was marred by the insistence of local social workers and health professionals to bring us down. Just recently, we have sacked our youngest paediatrician, since he also saw fit to report us for actively creating a non-existent disability. Obviously, we had paperwork from her initial diagnosis well before we adopted her, so that report was thrown out, but it destroyed our trust in him. We haven't had much experience with caring professionals, unfortunately. With a few exceptions, we have mostly had to fight constantly for everything that our kids needed with no support. We've had a lot of accusations thrown at us by professionals who don't understand the situation, the girl's history, or the youngest's disability. The social workers from the English local authority were great. Unfortunately, all of the ones we have worked with now have moved on, and several of the local authorities in that area have now amalgamated. So we no longer have any contacts there, except with the letterbox contact manager. The cardiologist who has treated our youngest daughter from the beginning received notes from his counterpart in England, and he has been very kind and supportive with us, never doubting her condition and always treating us as her parents, not just temporary guardians. So I'm going to take a moment just now to pause the recording, and I want you to think about why health and social care professionals can fail to help someone who is adopting. How should we support someone who is being failed by other professionals in adoption? And once the legal adoption is finalized, in some cases, support is still needed. How can we support an individual who still needs help? Okay, so health and social care professionals failing to help someone who's adopting. Sometimes this is about bias, and we think about bias within our practice quite a lot, especially when we're considering the Equality Act and equality and diversity policies. Sometimes it's about the fact that professionals only see a small snapshot of the story and don't necessarily investigate in the way that they should. But part of our role and part of our education, we need to think about supporting someone who is being failed by other professionals. So that's about having, again, that listening ear, not jumping to conclusions, making sure that we have read the prior case notes, that we have fully asked questions as much as possible, so that by the time we are providing our own reports and providing our own notes, that we are fully informed about the decisions that are being made and about the situation that is currently presented. If we're thinking about that legalized adoption process, we need to make sure that we're regularly touching base with those individuals. We need to make sure that there is a follow-up, to make sure that perhaps children with ongoing care needs are still having those care needs met. Making sure that perhaps if we're thinking about a child with a disability, that we're ensuring that that is followed through and that ongoing support is offered to make sure that that child isn't left without support, as well as the parents, who obviously will have their own emotions and their own feelings around this kid, around their own child. So we're going to look at the final part of Moira's story now, and we're going to talk a little bit about ongoing life with formerly looked after children. Education staff have been very judgmental and made several referrals to social work for a variety of reasons. Concerns about sexualized behavior, concerns around violent behavior, concerns about bruises on legs, a common occurrence with our youngest one's disabilities, and concerns about a lack of toilet training because she's doubly incontinent. We now seem to have built up more of a positive relationship with our oldest's mainstream school, since they have been implicated in some of her exaggerated storytelling and lies, and have a better understanding of her behavior. However, our relationship with our youngest special needs school is still very fragile, and communication is usually filtered through our current social worker. Our current social worker is much more sympathetic and somewhat more supportive of our situation. but doesn't always come across as being on our side. Her last report to the authorities in support of our case against the special needs school, who reported us for failing to toilet train our youngest, included references to our previous relationships and attempts to adopt through the local authority, which gave the impression that we were being evaluated in some way. We dearly love our children and wouldn't change them for the world, but our experience of adoption has not been a pleasant or positive one. It's been stressful, sometimes to the point of threatening the placement to break down, but we've stuck with it and with each other. We have become experts in our daughter's disability and in the trauma associated with children who've experienced neglect or abuse in their early lives. We deal with it daily, but the level of support we've received from professionals can be more accurately described as interference, not support. We're on the waiting list for both girls to be assessed by CAMS for different problems, but that was 2 years ago. I've taken on the coordination of planning medical appointments for our youngest daughter. She attends 12 different clinics across 5 hospitals in 3 local authorities. I ensure that continence products are ordered and sized correctly. I ensure that schools have the right information to be able to support our daughter's educational needs. I attend meetings and appointments while also providing a stable home life and an established routine. Oh, and there's that pesky thing called a career to throw in there too. So we're going to take a moment just now to pause the recording. And what I want you to do is to think about what other services formerly looked after children may need to engage with. How do we provide ongoing support to a family unit? And how often should we engage with families? And finally, education services play a major role in adoption. How do we support our colleagues from other professions for collaborative care? So take a few minutes to think about these questions, and when we come back, we'll talk through them. Okay, so formerly looked after children, the services that they typically need to be engaging with is thinking about our GP service. So making sure that once they have been placed and legally adopted, and during that legal adoption process, that they're registered with the GP, that if a child is of a particular age, that they're registered with a health visitor as well, to ensure that there's appropriate home support. We might need to think about perhaps care within the hospitals, so ensuring that children with long-term care needs are being followed up by paediatricians in our local hospitals. If we're thinking about providing that ongoing support for the new family unit, we need to make sure that if we are regularly touching base with the family, making sure that we have engaged with them, asking if they have concerns, making sure that we appropriately document their concerns, and making sure that if we need to collaborate with other professionals, that we do so in a timely manner. We should be making sure that we engage with these families on a regular basis. And this can start off as simply as touching base every couple of weeks, perhaps moving that to monthly visits, 6 monthly visits, yearly visits, just to make sure that ongoing support is provided. But obviously we're doing this in accordance with the needs that are expressed by the family. So we're thinking about that person-centered care. If they feel they want more support, making sure that we undertake that level of support that they feel they need. If we're talking about collaborative care, obviously the education service, we need to make sure that we are supporting our colleagues in the education. So making sure that we're touching base and sharing care plans between ourselves and the schools, between the schools perhaps and nurseries, Perhaps we need to make sure that we have a key liaison worker from each organisation to ensure that collaborative care can be met in the best possible manner. And there are a variety of different professionals that we can think about when we think about collaborative care, but it is important that we do come together and work as one unit rather than fragmented and disjointed services. So that is all for today's session. Thank you for engaging and for taking part in this session. We have references here that can be found at the end of this presentation. And these will obviously be available on the PowerPoint slides that are available through the college. Thank you for listening and goodbye.